I think this is actually going to be a great session because there actually may be some differences of opinion. So I'm going to start with the two of those. So patients in general, even though I think NCAN does have a video on clinical trials. So we have to understand that clinical trials, even if there's ample evidence in Europe or these things are been around for 20 years, the FDA does require us to prove it. And so clinical trials, you can't necessarily say something's better if it has not actually gone through the trial process, as much as we may love it. But I don't think patients quite understand clinical trials. So you actually have two clinical trials, and we remarked on a phase 3 before, right? But you are describing a phase 1/2A, and then is the action 1 a phase 2? Because it's going to be a phase 3. Okay. So first, let's start with, for patients that are looking at these clinical trials, what is a phase 1/2 trial testing?
Yeah. So when we're talking about clinical trials, there are, as mentioned, different phases. So when we're talking about a phase 1/2 trial, that's what we call an early phase trial. And what we are doing with those trials is this specific drug has been tested, not in humans, but has shown to be potentially useful in treating a certain type of cancer. So with a 1/2 trial, that is, we are looking to see what amount of that drug can we give that is safe for patients, but also delivers a therapeutic response. And once we can determine that in that setting, that trial could potentially move to a phase 2 and beyond to a phase 3 trial. And in those settings, we're looking more at a higher number of patients. More patients are going to be on that study, getting that dose of that drug that we determined in phase 1 to be safe and to be effective, to continue to study that drug, and again to hopefully find that is a beneficial therapy to move to approval.
Yeah, and then a phase 3 is that which is like, this has enough data to suggest that it may be as good as, if not better, or as an equivalent option for people, where then you wouldn't necessarily have to be flying all over the place or going to Europe for it. So I think it's just really important, because people that live in the world of clinical trials will lose sight of the fact that a phase 1 trial is actually not an effectiveness trial. We aren't testing whether or not it's actually effective. So I didn't want anyone leaving here thinking that a phase 1/2 trial would be considered a first line, like that's what we would be choosing first. But that they nicely did a phase 1/2, because the 2 means that it is an effectiveness trial, meaning there's enough data to support it. And now we're just looking at whether or not that dose has an effectiveness, of which then we would test it compared to some of the stuff that's available. So a phase 3, I think one of the other gentlemen remarked on a phase 3, is when we have a lot of data to support it, and that's when you get a lot of buzz around it, and that's a lot of the buzz about the alpha particle. So then, just so I can get a little bit of differences of opinion here. So Dr. Mehr, you made a statement on whether or not then PRRT would become frontline. Now, because he's got 2 surgeons here and someone from Iowa that's been a cytoreduction, he did temper it by saying after cytoreduction. So right. Dr. Howe, do you feel like when you're looking at this in Iowa, because Iowa has been also very, very good at promoting PRRT, anyway, so where right now is Iowa putting PRT when you're talking about some of the things we didn't go into a lot of detail with, but we did go into liver-directed therapy, ablation, cytoreduction, sandostatin, stuff like that. Where's Iowa putting this? And would you agree that the future looks like PRT is going to be frontline?
Just so what I said, cytoreduction is generally a good idea. The fewer tumor cells that are available to the radioactive material, the more of that radioactive material can go to those tumor cells. So we usually encourage cytoreduction prior to PRRT unless there's a reason not to do cytoreduction. So that's...
Well, we're in agreement.
See, I knew there'd be a little fire.
Tom Odorizio was an early adopter of PRT. Probably, we had a clinical trial open in the United States, probably the only one available, starting in 2001. And we sent lots of patients to Europe, to Basel, Switzerland, and Erasmus to get PRT through the 20 years before the approval of lutetium here in the United States. And so we've really led the charge in that for a long time, and we think it's a great therapy. But it doesn't kill all the cancer cells. It's really good at stopping the cancer for 2 or 3 years, at least with the lutetium. We're hoping with the alpha particles it'll be even better. But the earlier trials from Erasmus, and I wouldn't say they were even trials because they just treated everybody, but they suggested that patients did better if they had reduction or smaller tumors in their liver than patients with larger volumes of disease. So we've always kind of operated on the principle that if we could reduce the tumor as much as possible surgically, that PRT would be more effective. So we generally do surgery first, and then we'll try to get as much as we can out of just somatostatin analogs. And then when we eventually see progression, that's when we'll go into PRT, because as we've talked about today, there are a certain number of finite options for every patient, but there aren't that many options. And PRT is a really good one, but we save it because people can maybe get PRT once or twice in their lifetime in terms of cycles, because their bone marrow won't tolerate too much of it. So we save it for when we think we need it and for when somatostatin analogs are no longer doing the job. Joe leads our PRT group, and maybe you have some comments on that too.
Very enthusiastic about PRT, very enthusiastic about alpha particle PRT. We hope to be opening those same 2 trials in Iowa, but it's great that they're up and running in Omaha now. I think that every time that you visit with your doctor and things are, the CT scan is not stable, or the symptoms are not stable, or there's some question about, okay, what do I do next? It's important to look at all the cards that you have in your hand. Do I need to go back and do surgery again? Do I need to hike up the dose of the sandostatin? Do I need to do PRRT? I do think that PRRT will be moved up in the pecking order. But let us say a patient who goes and has surgery and has a tumor that's growing in their liver, everything else looks good. Do I want to give them PRRT radiation exposure to the whole body because they've got a tumor in their liver? No, I'd like to do an ablation or some other liver-directed therapy. So there are subtleties in it. I do think as a broad generalization, PRRT is coming up. Alpha particle PRT will be a huge advance. Super enthusiastic about it, but we got to consider it's there's that bone marrow toxicity. There is that potential for how much of this stuff can you have. It's important not to use it for things that we can take care of more efficiently some other way. So just a cold consideration of what are all of the options that we've got available, understanding that PRRT is a great option for many people.
I don't disagree at all. One of the things that we're seeing when we're doing liver-directed ablations, for example, is that radiation side effects, not just bone marrow, but to other organs of the body, are less when we do a liver-directed bland embolization as opposed to a Y90 embolization. So radiation side effects are you in agreement with that? Or?
Was that you or me?
I'm just
So-
a moderator.
So the issue here is talking about embolization, and you can embolize by just, clotting, putting a catheter up from the groin artery and putting it into the liver artery, and just putting in some beads in there, which blocks off the blood vessels to the tumor within the liver. Or you can use radioactive beads, smaller beads, but they get farther across the body. But when you use radioactive beads, again, you can only have so much radioactivity in your life. This is spoken as a non-radiation person, but you can only have so much radioactivity in your life. So do you want to use up part of your quota of radioactivity with radioactive beads in your liver versus holding off for PRRT? So again, subtleties in the decision-making process, but still very enthusiastic about doing bland embolizations or ablations.
Well, and I would just highlight that point too, because there are some centers that do bland and some do radioembolization. And radioembolization works really well, but if you're going to get PRT, they can induce a fibrosis in the liver and cirrhosis. And I just saw a guy on Wednesday who had massive ascites and had radioembolization previously, and then got PRT, and he's doing great. But now he's like 3 years after PRT. He's got massive ascites. His liver's about this big, and there's some disagreement in physicians who do embolization about whether that even happens. But I think we're seeing it more and more that people get radioembolization, then PRT will have this cirrhosis.
Yeah, we're seeing some very late cirrhotic changes in the liver in patients that had Y90 embolization, whether or not they've had PRRT. So our recommendations generally is to move away from radioembolization and use the more conservative bland embolization.
I'd agree with that.
There are some patients who don't have somatostatin receptors and therefore will not respond to PRRT. For those folks, I do think consideration of Y90 radioembolization may still be an option because they don't have the opportunity to benefit from somatostatin analogs. They don't have the opportunity to benefit from PRRT because they don't have those docking sites on those tumors.
Yeah, so what he's describing, because we really didn't have a really elaborate talk on liver-directed therapies, because that actually is kind of complicated in its own decision-making. But for patients looking at treatment, you kind of want to say, well, you want to take a treatment that has something shrink or melt or something where the after treatment image shows that something has worked. So some of us that have grappled with the PRT may not actually showing those types of changes, but still working and still being a great choice. So I will usually tell people that liver-directed therapies has been used for this disease for, is it 50 years now? At least 40 years. The platforms have gotten better, but that what Dr. Dillon was referring to is that an embolization technique is about directing a treatment directly into the core of the tumor. It's not going to care as much about grade. It's not going to care about somatostatin receptor avidity. You aren't exploiting the receptor. But the PRRT and lanreotide are dependent on the receptor being there. And I even thought that Iowa had some projects where they were trying to see, could I use something that would actually augment or improve receptor avidity in cells that were somatostatin sort of low in order to better try to choose some of these somatostatin targeting agents. But liver-directed therapies come with like an 80% chance in neuroendocrine, an 80% chance of having an appreciable response, like happy, 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 going to very unhappy with that technique, of which the 80% is no different if it's Y90 versus bland versus chemo embo. But I think that what Dr. Dillon's trying to say, that if we can't even target the somatostatin, so that's just PRTs out of the thing, the durability of the response, would we agree, is that Y90 is really well tolerated, and in higher grade tumors it may give you a little bang for the buck. Would you agree with that, Dr. Dillon? Yeah. Okay, so that went on to this because I think that this is also, I think, really important because you actually have an alpha particle, company here. The difference in time to progression between Lutathera and any active alpha particle that we have, whether or not that be actinium versus PB212.
I think the short answer is we don't know yet. But you said something interesting. Use the magic word tumor shrinkage. And I'd like to address a challenge that we have. Patients on PRRT therapy want to be imaged. They ask for it. And often patients will get conventional CT scans during Lutathera therapy just to see how they're doing. I think the days of doing medical tests because it's nice to know are at an end or coming to an end. But what we see commonly is a phenomena called pseudoprogression. That's when we look at a tumor and it's gotten bigger since the last imaging study. Well, with Lutathera, pseudoprogression is common because the tumors tend to swell, tend to become edematous, and when they swell, they get bigger. And in 2018, when the drug was first made available commercially, we would hear of a lot of patients stopping Lutathera therapy because their physician believed that the tumors were getting bigger and therefore progressing on treatment, and they stopped the treatment. So what we do is very early on, we tell patients about the phenomena of pseudoprogression, and we tell them that's the reason that unless there's a clinical situation that requires it, we don't do routine imaging during PRRT.
That's interesting that you should say that. So in those clinical trials, including the actinium-225 trial, do you not have interval imaging in those trials?
No.
Okay, so in the AlphaMedix trial you do. So you guys then went and did it very similar to how we were using. Is that true? No interval imaging in the action one? Yeah. So, but that is a really good point, because when Lutathera first came out and we were doing interval imaging, because we weren't actually sure whether or not, do people all need 4 doses, and it was healthy skepticism. And those interval imaging never really told us anything, and yet people still had a really good, durable, stable disease rate that lasted for what could be years of life.
We can do all sorts of metrics during treatment. Chromogranin A, serotonin, those are all valuable markers. The marker that I like the best is ECOG. How's the patient feeling on therapy? And I've gotten a lot of mileage using that marker.
Okay, and then so back to Dr. Howe. So because there is no sort of standard recipe, and one of the questions is about size and location and whether or not there are patients that are better or worse served for PRRT. But what has been your experience, Dr. Howe, in operating on people that have been previously treated with PRRT, so they can have complications either of the PRRT or tumor progression, and therefore in trying to treat the bowel obstruction, the ureteral obstruction, whatever it is? What's been your experience with operating on people after PRRT?
Well, there are a couple different populations, and one is people who've had liver progression after PRRT, and, I don't find that it's that much different. But the people that I think get into trouble are people with peritoneal carcinomatosis, and the tumors, which are basically implants in the abdominal cavity where the bowel can stick to them. For some reason, they get hot and things stick to them, and I've seen people with bowel obstructions that have been seemingly precipitated by having PRRT, and there's not much science behind it. There hasn't been a lot of descriptions of it, but Joe, we've certainly seen a number of patients who have had trouble, and we thought that PRRT was going to be the answer to peritoneal disease, but I think we're starting to second guess that. Joe, what are your thoughts?
Yeah, we've had patients who have a lot of peritoneal disease, who have a lot of abdominal pain to begin with. Those can get into this situation of bowel obstruction. We try to decrease that risk by giving them steroids, dexamethasone, prednisone, but some people, even despite those medications, can have bowel blockages or other problems. Now, it may be that if you can get them over that hump of swelling of the tumors, the pseudo progression that Dr. Mehr was mentioning, that they still will have a good benefit from PRRT long term, but it's a real problem, and you've probably seen that as well.
Yes.
Yeah, so I would say that then going back to Dr. Howe's point, when it's to take out the primary versus that don't take out the primary, I'd feel very uncomfortable in a metastatic patient, even if they have multi-organ site involvement, treating someone with PRRT with an unresected small bowel primary. Would you agree with that?
I would still do it, but the peritoneal disease is what would worry me the most. And why use that therapy first? Because again, we still feel that surgical cytoreduction and removing the primary tumor is better than PRRT. PRRT is very important in the list of things in the longevity of patients, but it's not, we wouldn't use it first line, unless patients are unresectable.
Yeah, like the surgery. Okay, so then back to the other end of the thing. What can you do, if anything, about the effects of damage on the bone marrow? So why don't we just go, because I think that bone marrow may get a bad rap because it's not like we see it that often, but that what can you do about effects of the damage? How often do you see it? And is there anything you can do about it?
Okay, we see transient reductions in hemoglobin, platelets, and neutrophils with every patient. And they generally, we expect that they come back, and they usually come back before the next treatment of PRRT. It becomes more of a challenge if the patient has had chemotherapy before PRRT, capecitabine, temozolomide, everolimus, the typical chemotherapeutic agents. The long-term bone marrow suppression that we worry about, the leukemias and so forth, we haven't been giving the drug long enough to really make a statement on that. I don't have anything else. Is that generally been your experience as well?
Yes. So up to now, we've only had the experience with the Lutathera rather than the alpha particle PRRT. But similarly, pretty much everybody, you'll see dips in those blood counts, and in general, they start to come back by a few months after the treatment. And the important role of prior chemotherapy, an important thing. We really don't know. I don't know if there's any theoretical benefit to alpha particle versus beta particle. I guess the jury may be still out on what happens to bone marrow in alpha particle.
We don't know. We've had alpha particle therapy for prostate cancer with skeletal metastasis available since 2013. The drug is radium-223 dichloride. The trade name is Xofigo, managed by Mehr, and issues haven't been raised. There's a small study, I don't even know if it was study or anecdotal, out of Europe looking at the projected incidence of myelodysplastic syndrome. That's when the bone marrow stops making cells. For all chemotherapeutic agents, for most all chemotherapeutic agents, that incidence is reported at about 2%. The study that was proffered said that with beta-emitting Lutathera, they expect the incidence to be 2% or slightly less than that. I haven't heard of any subsequent studies, but that's the extent of what I know.
Okay, and then since you brought it up, there was actually a question on NET and prostate cancer. So I think someone is asking about, how is something that we use for neuroendocrine related to the prostate, and the fact that we have a beta particle that in different formulations of the drug are used to treat both those types of diagnoses.
Scott and I have experience with prostate neuroendocrine tumors. Sometimes we'll see a patient with adenocarcinoma of the prostate, that's the garden variety of prostate cancer, do really well, and then begin to progress in a very unusual way. For example, the metastatic lesions that go to the bone won't be dense, but will be fragile or lytic. We'll see what we describe as visceral metastasis, or the prostate cancer is going to liver and sometimes brain and lung. That's generally a red flag, and what our prostate medical oncologists will do will re-biopsy those tumors. And commonly we'll see that they are neuroendocrine tumors now and not adenocarcinoma of the prostate. So we'll do a dotatate scan on those patients, and predictably those tumors will demonstrate abnormal somatostatin receptor expression, however, not to the degree where we feel that Lutathera will be appropriate. We use a metric in determining whether Lutathera will work by something called the Krenning score, and that just basically compares how much expression is there in the tumor compared to other organs in the body, for example, the mediastinum or the soft tissues of the chest or the liver. Now, people believe that the tumor didn't really change from adenocarcinoma to neuroendocrine. They believe that the tumor started out as two cell lines, and you've gotten rid of the adeno through a conventional therapy, and now the neuroendocrine is free to progress. Does that answer the question?
Yeah, it was a pretty general question.
Yeah,
but-
maybe, okay.
Yeah, okay,
Do you think
then.
it had anything to do with the radioactive PMSA treatments? Aren't you guys doing PRRT for prostate? Maybe that was where the question was headed.
Was that, are you talking about PRRT for prostate or neuroendocrine prostate? Because I may have answered the wrong question.
Yeah.
I was asking about the cell type, and you've answered that.
Okay.
Yeah.
Thank you.
It's a distortion of the cell type.
Okay.
Yes, but also I think what he was mentioning is that the prostate does have somatostatin receptor, so it comes up as one of those. Is that physiologic that we see in the prostate on the dotatate, or is that more than you would expect, which is when you're really happy you have a nuclear medicine like a PET imager that can really just determine whether or not they think that something is worthy of a prostate biopsy. Okay, and then Bob was saying if we wanted to open it up, we have one more question on PRRT, which is pretty much, is there a certain location or size for PRRT. So perhaps they're trying to figure out whether or not, are there certain things that would make it, better or a worse fit for a given, patient. But does size, why don't we just say, does size matter? Because I would say even in my own, I didn't mean it that way. Is that when you have, let's just say you have relatively large volume liver mets, like Dr. Howe had a very good image of things that are just not, you're never going to meet that 70% surgical cytoreduction and could all be very PET avid. If you have someone with multi-organ site involvement, small bowel, nodes, liver, bone, this other thing, but you have bulky somatostatin receptor avid tumors in the liver, does that matter with PRRT?
Well, make no mistake that when patients get into big trouble with neuroendocrine tumors, it's generally due to liver failure from the tumor. And we pay really, really close attention to that. Transaminases are one of the liver function tests. Generally are not helpful, especially if the patient has had prior therapies that affect liver function. But we pay very close attention to albumin and bilirubin. And once we are sure that any abnormalities in albumin are not nutritionally based, we aggressively go after those liver abnormalities. And if they can be surgically removed, that would be my first recommendation, and then following cytoreduction, PRRT.
And I lied. There's actually is one more question because I don't want people to think that I forgot their question. Yeah, so I'm going to read the question, then I'm going to say, well, maybe I'm going to get into the head of the person. It says, what causes PR treatment to not work? So why don't we just look and say, well, in patients who perhaps we thought the PRRT was a reasonable option, but I guess it doesn't have a durable rate of stable disease, or you actually have progression despite that. Can you sort of explain how that may be explained? Because I don't know the answer to it.
Well,
one of you two.
Well, initially we thought that the more avid the expression on the PET-CT, the better the response would be. And that's been promulgated over and over again. However, we've seen not an insignificant number of patients who've had so-so uptake on the PET-CT have enormously positive responses with Lutathera. Conversely, we see patients that have had a lot of avidity on the PET scan progress sooner than we thought. And we thought that may be to the fact that, well, there's so much tumor there, it all got used up before it could do its job. So it's another one of those things where we're not sure.
Yeah, so then I probably shouldn't be telling patients that it gets sucked out of their bloodstream based on the hotness of the scan. That's probably not even a remotely accurate statement based on what you just said.
I think that's probably an accurate statement, except there may not be enough in their blood to treat the degree of abnormality that they have.
I have also struggled to sort of say that when you can't control the distribution, so you may prefer to have a treatment go one way or the other, but when you are giving an infusional, if you're taking an infusional strategy, you just can't necessarily distribute it evenly to all of the places that you wish it would go. Is that I got a nod out of. Yeah.
Well, there are several balls in the air here. Number one is, and I don't know if this was discussed before I arrived or not, while we're giving you the Lutathera or the alpha particle emitter, we're also busy protecting your kidneys. Was that addressed at all? No? Okay.
That's the amino acid stuff that you.
Yeah. That's the reason you're there all day. The PRRT only takes, what, 45 minutes, Scott? Then why am I there for 5 hours? Well, you're there for 5 hours to make sure your kidneys are protected. So renal dynamics likely affect duration. Duration probably isn't the best word. How long the radiopharmaceutical will stay in the tumor, as well as other factors that we're yet to discover. So we know where it's going to go, but we don't know how long it's going to stay there. And that's a key issue.
I think another important issue is that when you have a lot of liver lesions, they're not all the same. They're not all low grade. Sometimes they're intermediate grade. Sometimes you might have a high grade lesion, and you might not know that. And those, the higher the grade, there tends to be less somatostatin receptors. So some lesions may not respond as well as others because purely of the grade of the tumor and the density of receptors.
And then one more question, Bob. Just one more question. I'm going to ask it for you. Is that so we will meet fork in the road where people will progress despite adequate doses of somatostatin receptor inhibitor. And then we're looking at whether or not the things that Dr. Howe talked about with sunitinib, afinitor, CAPTEM, and then, or we'll look at liver-directed therapies, or we'll look at PRRT options. So it seems to me, this is going to be an opinion, is it seems to me that now the question that is everyone's mind is that, so you gave PRRT for all the right reasons up front, and then someone goes 3 years and then shows progression of disease. And now we're at a fork in the road where, yes, you can look at all these other options over here, but you're looking at additional doses of the same stuff versus doses of alpha. How would you answer that question?
Well, there's a lot of experience with retreatment with PRRT, especially in Europe. And closer to home, Dr. Sandy McEwen in Canada has been retreating patients on a regular basis for many, many years without reported complications. It's Sandy's opinion and mine as well that when all of the dust settles and all of the safety issues are settled, PRRT will likely be given on regular intervals at varying doses throughout the life of the patient.
Yeah, so a patient, so I guess what I'm asking for, because if you're gonna search for clinical trials, is that if someone's being offered 2 additional doses of a beta, the Lutathera, that has worked for them, versus what you were talking about, some of the theoretical advantages to an alpha, is it going to be your strategy that you would then shift someone to the alpha, or would you say that is still, unproven but a very valid point?
We just don't have enough information to know about retreatments with alpha. We have a lot of information about retreatments with betas, and it's all very, very encouraging. The power of alpha therapy lies in its theoretical ability to better destroy tumor cells. What else it does is what we're learning now.
And as long as the bone marrow and all those other things
Right.
look like they can take it,
Right.
yeah, that you think that's a very reasonable ongoing strategy.
Yeah.
Yeah, would we all agree?
That question of do I do an extra 2 Lutatheras versus do I do an alpha particle PRT, that's what takes the time with the physician in the office. That's what you as a patient have to think about. It's to some extent it's what's your risk tolerance. We know what Lutathera PRT did to you the first time. We've got some reasonable idea of what Lutathera PRT will do to you the next time. It possibly won't be as good as the first time. We also have a new therapy here, which has high expectations, but we still don't know the long-term sequelae of it. So it's a risk-benefit talk. There's no right answer. I don't think.
Yeah, I think the data that we've seen from Dr. Del Pasan in Houston is that some people are having remarkable responses with the alpha agent that really encourage us. But the problem is not having the long-term data on toxicity to the bone marrow or the kidneys. Now, your second trial that you mentioned is developed by Mike Schultz, who is part of our SPORE group, and he's developed a new version of lead therapy, which is different from the stuff in Houston by just the linker that they use to the octreotide molecule. And in mouse studies, it looks like there isn't a lot of renal toxicity, and he thinks it's because the alpha particles travel not as far and don't injure the glomeruli as much, which all sounds great in mice, but you're humans, and we need another year or two, I think, before we know.
You bring up a good point. Actinium is not the only alpha particle that's being investigated. Lead is very, very promising. A lot more side effects with lead in the Houston studies that we're seeing. And there's others. There's thorium. There's many different alpha emitters that are being looked at. So well, it remains to be seen how all of this is going to shake out.
All very exciting. Bob, any
Okay,
final word?
before we go to a final word, I'd like to ask the audience, do you have any questions? I said at the beginning that we weren't going to do this, but we have time, and you've heard a lot of talk about PRRT versus other things. If you have a question, now is the time. Just raise your hand. Yeah.
As I understand it, that if you have been a recipient of the beta Lutathera PPRT, you could not apply for the clinical alpha at this point, correct?
That's actually just the opposite of that. So there are multiple trials that I discussed, but yes, if you received at least 2 doses of the Lutathera of the beta, and then you could potentially be eligible for the alpha emitter. Correct. That is correct as well. Now, there's a laundry list of inclusion-exclusion criteria that go along with every clinical trial, but that is the main point there, yeah.
Yeah, your prior exposure to beta PRRT does not exclude you. Actually, that's the patients that we are most interested in targeting now.
Any other? Oh, we have another question right here.
When do you think that the alpha-2 would be available besides clinical trials?
Eileen?
We are driving as fast as we can, working as hard as we can.
Maybe you can review how long it takes.
Exactly. The
To bring a
FDA does
drug.
not
It's,
move
I
quickly.
think, in a few years or something.
Years.
Yeah, it's a few years. Few years.
But that doesn't mean it wouldn't be available on these phase 3. So that's why I really want people to understand clinical trials, is that once you're going into a phase 3, for some of our patients in the South that don't even, they can't even get PRRT standard of care. So to be able to give people that medicine on a phase 3 is as close to it being readily available as you can get, other than your local person, even though you guys have a local person, would not be able to pull it off the shelf like they can pull off Lutathera right now. So it will be available on phase 3 trials, and then I think the institutions that house those trials and the sponsors of those trials make it as accessible to all walks of life, all parts of the country, and the only really inconvenient thing is the fact that you may have to travel across state lines to get it. But for example, in New Orleans, we actually have a housing unit for people. So they are doing their best to make it as convenient or least inconvenient as possible.
Okay, another question over here.
Okay, so if you don't qualify for an alpha trial now in a phase 1-2, is there a possibility you could qualify when it gets to a phase 3?
Potentially. I guess if I understand the question, again, with every clinical trial, there is going to be a laundry list of inclusion and exclusion criteria. The two that I am familiar with, or that we do have available here in Omaha, the one is pre-Lutathera, and that's the phase 1 study using the lead, and then the other one would be following Lutathera, following at least 2 doses of the Lutathera, and after progression on that. Did that answer the question, or?
He did not qualify for the first trial because on his first PRRT, he had the MIBG. I was talking to you about that.
He
with
had
the
such, I
Lutathera.
think her response was that, you know how in Europe you could get a combination of radioisotopes, and for a variety of different reasons based on size and things like that. And so I actually wasn't familiar enough about the inclusion or exclusion criteria on the exposure. So say, for example, we're only talking about the ones that are targeting patients that had previously exposure to whatever particle. Is that you could only have been exposed to the beta, the lutetium-177 Lutathera, or if you were exposed to any other radiopharmaceutical, whether or not that be yttrium-90 into the liver or MIBG or whatever may have been used. She was unfamiliar with the radioisotope that was used.
I would have to double check on that, but yeah, the main inclusion would be a patient that has had exposure to the Lutathera, was stable for at least 6 months and then progressed after that. I don't believe there's any other exclusionary factors around radiotherapy, though.
Actually, we did have this issue coming up with the RaiseBio trial, and people who've had an alternative form of beta particle PRRT, which was available in Europe and Iowa, yttrium-90 PRRT, are not qualified for. RaiseBio do not accept yttrium-90 PRRT, and I think we've had problems with the MIBG with one of the ongoing trials. So inclusion and exclusion criteria are different for each trial, unfortunately, and the devil is truly in the details.
Yeah, and just for people that don't, all those are just different radioisotopes that have, they're different rationales for giving them. But.
Question?
Yeah, so if you've been approved for PRRT, but and you've done all the tests, but you chose not to do it right away because you've been fairly stable, but things have changed, can you do the trial for the people that have not done PRRT yet? Did you say there was one that you could do if you haven't had it done? You could do it
Potentially. And I'm assuming you're referring to the trial that's the frontline pre-Lutathera.
Right, yes,
okay.
yeah.
And my understanding is it has to be within a certain amount of months from diagnosis. But again, the inclusion exclusions are very pages long, and it would have to be a situation where we really look at the patient's chart and do a deep dive into that to see if they were potentially eligible. So.
And if you go to clinicaltrials.gov, it will include kind of maybe not the total nuances of it, but it does go into it where you would be able to say, is that me, is that me, is that me, and then you would be able to just contact whatever center has that trial, and they'd probably be able to answer that question pretty easily, because those are all going to be patient specific.
Any other questions from the floor? Well, I have a question. It's a little broader, but I think it's very important. You have a patient comes to you and is diagnosed and now has a NET, and they know that. And what are the 2 or 3 pieces of information that they absolutely have to leave your office with? And like, for instance, I'm thinking down the lines, we have people call, or hotline and things like that, and they say, okay, I left my doctor's office, I have neuroendocrine cancer, what's next? And you say, well, what's your Ki-67? And they go, what's that? So, I mean, what are the key important points that patients should leave the office with when they're diagnosed?
So I would like them to leave understanding what grade is, what stage is, what significance of those two issues are. The grade goes back to your KI 67 staining. The stage is how extensive or how widespread it is, because both of those things are going to really shape some of the therapy going forward, whether it's a functional tumor or a not functional tumor, and then what are the sort of handful of therapies that are open to them, but knowing their type of neuroendocrine tumor, whether it's functional, what grade it is, what stage it is, I think they could go into the next doctor and say, I have a PNET which is 2 centimeters functional and is stage 4 and grade 2, and that next physician should get a pretty good idea of what we're talking about here.
Has anybody had that kind of an experience where you left the doctor but you really weren't sure what you had? You get some good doctors, that's for sure.
Yeah, if
Well,
I were to
very
actually
good.
just bring up one thing that I think all of us are going to agree on, is that, so, Marion and Bob and this organization will go about the need for multidisciplinary care. It starts to become a cliche, multidisciplinary care, like what does that mean? And I think for the surgeons, we would prefer the opinion for or against surgery to come from a surgeon who's comfortable in neuroendocrine. So if I were to tell anyone going out of any office, is that if they don't feel like they truly understood all of the options, that they would just reach out for a second opinion so that they could at least understand those options. So a lot of times you may be getting that opinion because sometimes we will use a tumor board. That's when we all just get around one day a week because you just can't get all the physicians in the same clinic at the same time. But philosophically and programmatically, we should be, it may be one voice, but that we should be giving a unified opinion. But that if you aren't then in sort of a neuroendocrine subspecialty environment or somewhere where you have specialists that are very familiar with cytoreduction and or chemotherapy or anything like this, is that sometimes I think patients won't necessarily get the whole picture. And so the medical oncologist will go, so what Dr. Dillon was saying, they will go with stage over grade. So then they're just always stage 4, and it seems like this. But really, when we're looking at it from a surgical perspective, the grade, the KI67, becomes almost the heaviest variable in the making of making decisions based on that. Yes, and so a multidisciplinary does not mean, I just don't want the patient to be a ping pong ball from office to office to office to office in order to get a cohesive opinion on all of the different therapies there is, because as I think you've gotten here is that if you go through the guidelines, the NCCN guidelines, which is what we're supposed to at least try to put in perspective, you get neuroendocrine, and because each of those decisions is so patient specific that every single one of these options comes up with like, okay, you can do this, 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 or this, but each of those options is weighted very similar, and you have to know. Like, but in your case, why would one make more or less sense? So that's when we're talking about multidisciplinary. It's just that we would prefer you to have all of the options that laid out to you, because even people make decisions differently. People may say, you know what, I just don't want an operation. Some people will just give up on chemo, even though it's a great, option. But the so would you? I think you probably run a multidisciplinary, probably a really good multidisciplinary clinic.
I would say that you can go to some very good institutions in the U.S. and get different answers about what treatment you should get. And I think it's helpful to hear it from different specialties. If they congeal on the same kind of therapy, I think that's very helpful. I mean, the old adage that if you're a carpenter, everything looks like a nail. So if you're a medical oncologist, your inclination may be to use everolimus. If you're a surgeon, you might want to operate. If you're an endocrinologist, you might want to give somatostatin analogs. If you're nuke med, you want to give PRT. But, you know, multi-specialty groups understand the interplay and the role of each of those. And sometimes you go to a medical oncologist who doesn't have those other factors available, and they're just thinking like the carpenter. So I think having the multidisciplinary group.
Sorry, you're out of batteries.
Okay. Having the multidisciplinary group is really helpful, and if you're hearing similar things from multiple people, that's probably the right answer. So sometimes it's just difficult if you're just hearing from one person.
Yeah, especially if you're saying, oh, is my local area good enough for what it is we want? I would never, ever tell someone that a second opinion is anything other than extraordinarily valuable. If you hear the same thing or something very similar, which I think is exactly what you're saying, something similar out of two people's mouths, all of a sudden you are so much more comfortable with the decision that's being made. And then in certain parts, so the neuroendocrine specialist, where we have like 100% neuroendocrine, we couldn't take care of all the neuroendocrine anyway. So for us to be able to have local people that can do it is this. We just want to make sure that you guys are getting the best opinion, and not just because that's kind of the specialty group that you've got. Yeah.
I'm fortunate to be part of a medical oncology group, and I get referrals from medical oncologists in two different scenarios. One, the medical oncologist wants PRRT, and they want me to evaluate the patient. The other, which is becoming more common, is I'm referred to see a patient who is newly diagnosed with neuroendocrine and explain what one of the treatment options may be down the road, so that when it becomes time for that to happen, the patient is more comfortable. One of the things that I do when I see the patient in that setting is I discuss some of the side effects or the consequences of neuroendocrine tumors that will affect my decision. And one of the major ones is cardiac involvement of the tricuspid valve of the heart. I've had one patient that has had 2 valve replacements. So when I evaluate a patient for PRRT, they all get echocardiograms, all of them. And if there's something going on in the tricuspid valve, that doesn't mean that I won't treat them. That just means I make a cardiologist a member of the team as treatment progresses. So there are a lot of little nuances that if the patient hears about it early on before they need it, if and when they need it, there's a higher level of comfort.
Yeah, I totally agree with that too. When the multidisciplinary team, it's even just to get the head around it, because then they can look it up and generate any additional questions, even if that's not the decision at the moment.
Hold on. Okay, okay, now you can hear me. Okay, are there any other questions from the floor at this point? If not, we have another question.
I'm just curious as why, like, Europe and Switzerland is so far ahead of us. Like, well, and also thank you guys for all that you do for our loved ones. We really appreciate it.
Is that for me?
Regulatory, yes.
Okay. When a drug gets approved in this country for the first time, all of the data needs to be generated under the auspices of the FDA, correct? Which means we have to reinvent the wheel. Okay? There's a lot more freedom to practice medicine in certain countries in Europe, and Germany comes to mind. A medical doctor who sees patients is always referred to as doctor. An academic physician is always referred to as professor. If you carry the designation of professor, you're allowed to do a whole lot more without regulatory oversight than we can do in this country. Giving alpha emitters and beta emitters together have been tried in Germany. You name it, they've tried it. So regulatory oversight is the reason, in my opinion. Do you agree?
I just want to add that, PRT was given in Europe for decades, and they just gave it to people, and they figured out about the toxicities along the way, and I don't know what kind of consents they had to sign, but they had amassed over 1,000 patients by the mid-2000s in Rotterdam. And it wasn't until that the trial was done in the US and in Europe with the NETTER-1 that it was actually shown in a randomized fashion for the first time where everybody could believe that there was a benefit to PRT. So they never really did the studies over there to prove that it was better than just giving sandostatin alone. And it wasn't until those randomized trials were done here, and you guys were a member of the NETTER-1, and so were we, and that actually proved it. But over there, they were just giving it to everybody, and they would change isotopes. And the gentleman they're talking about in Germany is a pioneer, but he's used 10 or 20 different isotopes, and I'm sure not everybody benefited from that. It was sort of experimental medicine, and maybe some did benefit, some didn't. But a little bit of the Wild West in some of those places. But I mean, they certainly were pioneers and did a lot of good work for people. But a lot of people early on suffered the side effects of renal toxicity from the yttrium-90, for example. A lot of people, ended up with bad kidney disease, and it was really credit to the group, pioneered by John Strasberg in Tampa, who led that NETTER-1 trial here to finally show for the first time in a randomized fashion that it's better than sandostatin. So it's different.
I just want to make a little comment. About a year ago, there was a drug that was supposed to come out and be FDA approved. Unfortunately, the studies weren't done here in the US, they were done in China. So the FDA, even though it was a good drug and they had great responses, they would not pass it. And a lot of these drug companies, you don't realize how many millions of dollars and how many years they're in clinical trial. And now they have to start all over again for the US. So it does take a long time. And that's why, it's really, really important for us to help with the clinical trials because we need these drugs. And it takes forever for them to get through. And like I said, this has happened over and over again where we've had a really great drug, but they didn't have enough US patients the FDA was like, no, we can't use this drug. And so that's the really sad part about it. Europe, they don't have those regulations that we have in the US. Very sad. Any other questions? Okay, so there's some brownies, because you didn't eat enough. Some brownies, cookies, and pretzels out there. Have something to eat. We're going to take a 10, 15-minute break. We'll come back. The doctors will give their last comment, and then we're going to network for the group.